Good afternoon. Welcome to Improving Hepatitis B Prevention, Screening, and Clinical Care for African Immigrants. This is the third webinar in our series focused on African immigrants, HIV, and hepatitis B. During the presentation, all participants will be in a listen-only mode. You may enter questions throughout the webinar by using the chat feature located in the lower left corner of your screen. Questions will be answered at the end of all three presentations. Please make questions clear and concise. As a reminder, this webinar is being recorded. This webinar is sponsored by the Multicultural AIDS Coalition, the oldest minority AIDS service organization in New England, dedicated to mobilizing communities of color to end the HIV/AIDS epidemic. The Multicultural AIDS Coalition's Cultural Competency Series is supported by the New England AIDS Education and Training Center, NEATEC, Minority AIDS Initiative, through a grant from the Health Resources and Services Administration, HRSA. Continuing education units are offered for nurses and social workers. To receive continuing education units for this program, participants must 1. Read the learning objectives and faculty disclosures, 2. Attend the program in its entirety, 3. Answer any polling questions presented, and 4. Complete an evaluation form. A certificate will be emailed to participants within 4 weeks. The speakers and planning committee members for this course have been asked to disclose any significant relationships with commercial entities that are either providing financial support for this program or whose products or services are mentioned during their presentations. There are no disclosures to report by speakers and planning committee members. The training objectives are provided. This webinar is designed to be interactive. Participants are encouraged to ask questions throughout the presentation via the chat box located in the lower left corner of your screen. Questions will be answered at the end of all three presentations. Immediately at the end of the training, you will receive the evaluation. Keep your web browser window open, and in place of the webinar screen, a pop-up window will appear with questions. Please complete. The evaluation will provide vital information to help improve the webinar and also document who participated. Now I will invite Denise Hyatt, Regional Resource Coordinator from HHS HIV/AIDS Regional Resource Network Program, to get us started.
Hi, thank you, Rachel. Before we have our first presenter, we would like to get a sense of who's participating on the webinar. So if you could please enter your tally now underneath your primary service that you provide within your organization. Great. So it looks like we have the majority of folks participating from non-clinical organizations, for example, community-based organizations or other community partners. And then next we have other, which is interesting. And so that's good information for us to know. And for presenters, please be mindful of this as you're presenting your information to the participants. Our second polling question is asking what is your primary role at your organization? Okay, so it looks like our answer is other there. So I imagine that there is a good amount of folks from probably serving in various capacities within community-based organizations. And outside of that, it looks like there's a good mixture of other clinical, social work, community health, and administrators. So it's nice to see there's a good mixed representation of folks during the call. Thank you.
Now we will have our first presenter, Chari Cohen. Chari Cohen is the Director of Public Health for the Hepatitis B Foundation. For the past 14 years, she has planned, implemented, and evaluated community programs and research projects focusing on hepatitis B and liver cancer. Her research focuses on reducing hepatitis B-related health disparities, including determining barriers to and developing culturally competent models for improving healthcare access. She is also co-founder and director of Hep B United Philadelphia, chair of CHIPO, Coalition Against Hepatitis for People of African Origin, and co-founder and advisor to Hep B United. Ms. Cohen received her MPH in Community Health Education from Temple University in 2001 and is a doctoral candidate at Drexel University School of Public Health.
Thanks very much. Can you hear me?
Yes, we can.
Okay, wonderful. Thank you. I'm going to talk about a little bit today about hepatitis B virus and some of, so first we're going to do a definition. We'll talk a little bit about the epidemiology of the virus, transmission and prevalence, and then I want to focus a little bit on the gaps and the barriers with chronic hepatitis B infection, some of the most affected groups, and particularly some of the barriers that are faced by African immigrants in the U.S. in terms of screening and linkage to care. So hepatitis B is actually the most common serious liver infection in the world. It is a virus that infects the liver, and it can cause both acute, which is short-term, or chronic infection. So when someone has an acute infection, it means they're newly infected, and most adults who are infected with hepatitis B are able to fight the virus off and recover within a few months. There are those people who are unable to fight the virus off, and that is particularly true for people who are infected at a young age when they're babies or young children. Those people develop chronic or lifelong infection, and that means they're unable to get rid of the virus from their body, and they are at a much higher risk for liver problems such as liver cancer, cirrhosis, or liver failure. Hepatitis B is transmitted through direct blood-to-blood contact, through sexual transmission, and also from mother to child during the childbirth process due to the blood exchange that takes place. And just for your reference, mother-to-child transmission, which is what we call perinatal transmission, that is actually the most common route of transmission worldwide. And what that means is most people who are infected with hepatitis B through perinatal transmission, through mother-to-child transmission, most of those folks will develop chronic infection because they are infected at birth. And you're going to see high chronic infection rates in those areas of the world, as well as high morbidity mortality rates there. Hepatitis B is not transmitted by casual contact. Hugging, kissing, coughing, sneezing, all of that, breastfeeding, that is all fine. Eating food prepared by someone who has hepatitis B is also not considered to be a transmission route. Hepatitis B virus is preventable. In fact, we call the hepatitis B vaccine the world's first anti-cancer vaccine. And over 3 billion doses of the vaccine have been given out in the world. Hepatitis B can be prevented with 3 doses of the hepatitis B vaccine. It's important to remember that the vaccine prevents hepatitis B infection, so it doesn't work in someone who's already infected. And like we mentioned before, people who have chronic hepatitis B infection are at greater risk for liver disease, and a staggering 25% of those who are infected when they're young will die prematurely from cirrhosis, liver cancer, or liver failure. And you can see in the next slide, this is a map of the world that looks at the prevalence of hepatitis B virus. And you can see the darker areas of the world are most infected, have the highest prevalence. Those would be areas that have hepatitis B prevalence of greater than 8%, which is incredibly high. And the light green areas have an intermediate infection rate, which is between 2 and 7% of the populations there are infected. You can see already where we might have some trouble in the United States when we have immigration coming from endemic areas of the world. So not only are you going to see high morbidity and mortality in these areas, but in our new immigrant populations, you're going to also see high morbidity and mortality. And so the question is, what can we do in the United States to help prevent those unnecessary deaths? So we have now our first poll. You can go ahead and respond. Most people in the United States who have hepatitis B are aware of their infection. Going to give it about 5 or 6 more seconds, and then we're going to close the poll. Okay. Wow, you guys are good. So here it looks like the majority of people do not think that most folks who are infected are aware of their infection, and that is actually true. What we know in the United States is that about 2 million Americans are chronically infected with hepatitis B, primarily those who are foreign-born and who are or second-generation Americans. They have the burden of chronic hepatitis B. They carry the majority of infections in the U.S., and that's where we also are going to see morbidity and mortality. And what we also know is that while hepatitis B disproportionately affects people who come from Asia, the Pacific Islands, and Africa primarily, these are also the groups who have the lowest rates, lowest access to care, and they often have multiple barriers to hepatitis B screening, which we're going to talk about. There are some critical gaps. Only about 30% of infected individuals in the United States are diagnosed with hepatitis B, which means that the majority of people who have hepatitis B infections don't know that they have it. So what you wind up with is a situation where not only do you have only a small percentage of people who are diagnosed, but for the most part, once someone is diagnosed with hepatitis B in the U.S., it is difficult for them to get into care. So we often have a situation where people will know their infection status, but then they're unable to get follow-up care for it. And without follow-up care, very few people are able to get the treatment. So while there is no cure for chronic hepatitis B, there are FDA-approved treatments. And so if you're unable to access care, you're not able to get treatments. And the treatments can slow down progression of disease and potentially prevent end-stage liver disease or liver cancer. And so it's very important that we're able to get people into care. So this slide shows kind of what we call our cascade. So you can see the first bar, the high bar, is the number of chronic infections, and it's up at 2 million. These are the number of chronic infections in the United States. And you can see a very swift curve. The next bar is the number of people who are aware of their infection, and that's about 30%. And then if you go down, it's the number of people who are able to enter care. Also very, very small, about 15%. And then if you look at the last bar, even though we have 2 million infections in the United States, only about 50,000 prescriptions for treatment are written. So there's a huge gap there between the number of people who have chronic hep B in the United States and the number of people who are getting treatment for it. So what's going on? Why are people unable to get screening and linkage care for hepatitis B? So what we know is that it's a multifactorial problem. There are lots of determinants that go into why a person is unable to get hepatitis B test or to get into care. Some of it is what we call individual determinants, where a person's cultural beliefs or the beliefs or knowledge about a specific disease. So what we know is that among high-risk communities in the United States, there tends to be very low level of hepatitis B knowledge, or there is some misinformation. So it's very common for people to either they don't know that they should be tested for hepatitis B, or they know that hepatitis B might be a problem in their community, but they don't want to know that they have it because they have, they don't know that there are treatments for it, or they feel like they might be stigmatized for having a hepatitis B infection. We do know that hepatitis B is a stigmatized disease. So there's a whole host of reasons why someone might not seek screening, why they might not go to the doctor and ask for screening. And from the clinical perspective, hepatitis B has typically not been screened for routinely. And some of that has to do with our general knowledge as well. Hepatitis B tends not to be a disease that is very well known in the United States. It's not something that we talk about. And even among the clinical community, at the primary care level, it's not something that's generally on the radar screen of many primary care providers. And so you wind up with a situation where, first off, people often have limited access and can't get to a doctor. And then if they do get to a doctor, they're not going to ask for a test, and their doctor's not going to request that they get tested. And so you wind up in a situation where people aren't getting screened. What we do know is that if a doctor recommends testing, a patient's 4 times more likely to be tested. And if a doctor recommends testing and a patient also asks for testing, so in other words, so the doctor has some awareness of Hep B and the patient also has some awareness of Hep B, they're 8 times more likely to get tested. And what that gives us is a hint in terms of where we have to go. How do we get people screened for hepatitis B in the United States? You educate the high-risk communities and you educate providers. So it looks like we have another poll, another question. In the communities I work in, the following serve as barriers to healthcare access. So we'll go ahead and give a few seconds for that. If you want to choose one that you think might best describe your population. I'm just going to give that a couple more seconds. Okay, so out of 46 responses, wow, all of the above. So it looks like in the communities that we're serving, it looks like there are multiple barriers to healthcare access. And again, I think very much like other diseases in high-risk communities, we are going to have to make sure that we're addressing these barriers at multiple levels. We have to be able to address things like belief and awareness and English proficiency and health insurance access. So you're looking at multiple levels of barriers here. In terms of African immigrants, there are a number of specific barriers that we have found. I will caveat this by saying there is not a ton of information out there. Hepatitis B is not, in African immigrants in particular in the U.S., has not been researched over much in terms of barriers to healthcare access. But what we do know from the communities that have done some research is that, in particular, lack of insurance is a huge barrier for African immigrants, particularly newer immigrants to the United States. And what I work in Philadelphia, and what I can tell you from what we've learned in Philadelphia in particular, is that being able to navigate the healthcare system is a big barrier for a lot of our African immigrants, where the U.S. healthcare system is so very different than the system they're used to. And even something as simple as, having to make an appointment for a test to see a doctor is very different. So we also know that particularly in Philadelphia, and I know in other cities as well, language is a big barrier to healthcare access, and just specifically for hepatitis B screening, it can be an issue. And even in the hospitals and the clinics and the providers that have access to something like a language line, that doesn't always necessarily reduce the barrier, because we all know that the language lines over the phone don't necessarily work as well as having someone in person who you can speak with in your same language. But there often is a lack of understanding when you aren't speaking the same language as your provider. And also low rates of hepatitis B awareness among African immigrants we find is a reason for people, particularly when people feel well. So hepatitis B tends to be a silent disease, and that most people don't have any symptoms until they have until they've progressed through to serious liver disease. So what we know, particularly in new immigrants in Philadelphia, we found that when people feel well, and then you add that to the idea that they don't really know about hepatitis B and they don't think that it's a very serious problem especially because they feel well, they're much less likely to seek out a test for hepatitis B. So how do we test for hepatitis B? Now, I know that most of the folks on this call are not clinicians, but it's really important to know that the big picture here is that hepatitis B is a very simple disease to diagnose. It is one simple blood test that someone can take to tell them what their hepatitis B status is. In most cases, any primary care provider should be able to test for hepatitis B. We always tell everybody it's one simple blood test that can save your life. And so the nice part about the blood test is that not only will it tell you if someone is infected with hepatitis B, but it can also tell you if they're protected, if they're immune to hepatitis B, or if they need vaccine. So especially in a setting where we work in a community, in high-risk communities, it's really nice because then if you find out someone's infected, you can refer them to care. But if you find out someone needs vaccine, then you can refer them to vaccination and hopefully navigate them into vaccine services as well. So it's nice to be able to tell people what their status is in a very simple way. Who should be screened for hepatitis B? Well, according to the CDC guidelines, that are backed up with new guidelines from the United States Preventive Services Task Force, anyone who is at high risk for hepatitis B should be screened. And that means that anyone who is born in a country where hepatitis B is prevalent should be tested for hepatitis B. And anyone whose parents were born in a high-risk country should be tested for hepatitis B. Now, of course, there are other communities that are affected. For instance, all HIV-positive individuals should be tested, and then folks who have behavioral risk factors, such like injection drug users or men who have sex with men, and finally, household contacts or sexual partners of infected individuals. These are all groups that would be recommended for hepatitis B testing in the United States. There has been a very strong federal and community response to the lack of screening and linkage to care in the U.S. In 2010, an Institute of Medicine report came out, and it was published, and it highlighted some of the very big gaps that we have in viral hepatitis, including hepatitis B. The federal government does have a viral hepatitis action plan that was just updated in 2014. You can go online, you can print it out. And the plan really highlights how federal partners can work together with community partners and what we can all do at our own local level to increase screening and linkage to care. There is a multilingual hepatitis B campaign called the No Hep B campaign that is run by the CDC. The campaign is fairly new, and so far it is in Mandarin, Korean, and Vietnamese. We are hoping that as the campaign grows, they will be adding some of the other languages and hopefully some African languages as well in the future so that we can reach lots of high-risk groups around the U.S. and improve their awareness. And then finally, we have the CHIPO National Coalition, which is the Coalition Against Hepatitis in People of African Origin. We are a very loose national coalition, and we have about 49 coalition partners around the U.S. And our goal is just to share information and share best practices to help people get educated, get screened, and get into care. And I know my contact information is in the slides. Anyone who is interested in joining CHIPO, we have a very strong group of dedicated people, and we're here to make sure that around the United States that hepatitis B is not forgotten and that African immigrants are not forgotten. So please join us. I think I'll skip that. And the last thing, in the interest of time, the last thing I wanted to just let everybody know about is that there is a World Hepatitis Day. It is July 28th, and it is a campaign that happens around the world. There's lots of really cool events that you can plan in your local community. Something as simple as printing out a poster, posting things on social media, joining thunderclaps. The more awareness that we create surrounding hepatitis B, the more we will be able to get people screened and diagnosed and into care, and the more lives we'll save. And finally, I just wanted to let everybody know that we do have NIRA Day, which we are trying to create a United States Awareness Day for HIV hepatitis in African immigrants. And so if you click on that link, you can help support us in our effort. And that's all I have. Thank you.
Thank you, Chari. Our next presenter is Erin Vanderhoff. Erin Vanderhoff is a project coordinator of a unique partnership between the Hepatitis Outreach Network Home and African Services Committee in New York City. His work focuses on reducing health disparities among foreign-born persons from regions where hepatitis B is highly endemic. In conjunction with the Tisch Cancer Institute, Erin has been part of research studying African immigrant community knowledge, attitudes, and behaviors to create a culturally proficient health intervention with respect to hepatitis B. Most recently, he has worked with ICAP at Columbia's Millman School of Public Health to help develop educational and anti-stigma Ebola radio and print PSAs. Erin received his BS in Integrative Neuroscience and his BA in French Language and Literature from Binghamton University in 2012.
Thank you. So I'm going to be talking a little bit today about the Linkage to Care program, the screening linkage to care program that we have at African Services Committee and as part of the Hepatitis Outreach Network. So I'd like to just start off with a polling question, but just a little caveat, and you'll see here in a minute. It's actually the third answer is actually greater than or equal to 8% and not 7%. So I apologize about that, folks. But if you would go ahead and we'll test your knowledge on what Chari has already shared with you. All right, we'll just give it just one more moment. So it looks like most of you picked the right answer. It's actually greater than or equal to 8%. And in fact, as you'll see here in a bit, the rate of hepatitis B surface antigen in the population that we've studied here in New York City is actually more around 12%, which is extremely high. So African Services Committee and the Icahn School of Medicine at Mount Sinai's Hepatitis Outreach Network has this partnership where we kind of pair the clinical expertise of Mount Sinai with the community-based knowledge of African Services Committee. And we provide hepatitis B and C prevention, screening, and linkage to care. We do on-site and off-site screening for both hepatitis B and C. And we focus primarily on those with intermediate to high risk for hepatitis B and C. So we're talking about between greater than 2% for the folks for hepatitis B. And Chari's kind of really already covered pretty much the basics of hepatitis B. But to really focus on the West African aspect of it, like I said before, we're looking at rates of greater than or equal to 8% for most of West Africa. Again, this is a map kind of showing where the prevalence is, and as you can see, the dark region is where it's West Africa primarily, and that's where we see the greatest concentration of those high rates of hepatitis B surface antigen. The thing about hepatitis B progression is that it's not this linear kind of progression like it is with hepatitis C, where you go from having a normal liver to having fibrosis, cirrhosis, and then you end up with hepatocellular carcinoma or end-stage liver disease and eventually death. The thing about hepatitis B that's different is that you can actually end up with liver cancer or hepatocellular carcinoma before actually developing liver cirrhosis. And you'll see kind of like why that's important here in a bit. Just to give you a little bit of background about African immigrants in the United States, there's been quite a bit of an uptick in the total amount of African immigrants living in the United States. As you can see, a 7-fold increase between 1980 and 2009, for a total of 1.5 million persons. They represent a really, really small part of the total U.S. population, but are actually a huge portion of the people who are infected with hepatitis B living in the United States. And a majority of those sub-Saharan African folks are actually from West Africa. They contribute a high portion of the folks who are actually infected with hepatitis B. And our own screening program has found the burden of hepatitis B to be around 12%. And this number is actually from 2013, but still in 2015, our screening program has found it to be about 12% of the people that we screen that are from West Africa are hepatitis B positive. Chari also spoke a little bit about kind of the federal response, and basically it was to come up with this action plan based on the recommendations from the Institute of Medicine and other groups, including recommendations from the AASLD. A lot of research has been done to supporting this action plan, not only for hepatitis C but also for hepatitis B. But we know that we can't approach things similarly for one particular subset of the population as another. So things that might work in one particular population might not work in another. And I think Chari kind of highlighted some things in the previous presentation, talking about the kinds of barriers that Africans face when trying to access medical care here in the United States. The goal of our program is actually to identify the people who have hepatitis B by using outreach workers and patient navigators, identifying whether or not they are infected, whether or not they need to be vaccinated, and also we're trying to increase the amount of education about hepatitis B in our community here in New York City, which is mainly in Upper Manhattan and the Bronx, although we do screen and educate in all 5 boroughs in New York City. So the way that we kind of have been going about it is actually engaging gatekeepers, so leaders of community, ethnic, and faith-based organizations. And we do this by means of traditional means, so we do this through print and radio, and posters, advertising, that kind of thing. But we also do some advertising through non-traditional formats, such as internet radio and most surprisingly conference call radio, which is internet radio basically by way of having a conference call kind of like we are now, except for everybody is on mute except for the host, and it's essentially like a call-in radio station, and we found a lot of success in advertising on these kind of invisible radio stations. Like I said, we screen here at African Services Committee, where we have kind of a home base, and then we do off-site screening with our mobile unit in churches and mosques and community centers, taxi garages, even public schools and parks, and pretty much anywhere else where folks would assemble, such as community-based organization headquarters, things like that. If they are found to be infected, they're seen at Mount Sinai, or or another one of the hospitals that we work with, and where they receive a workup, they'll get a treatment recommendation, and then we can then we end up referring them accordingly. So if folks don't need treatment, then they need to be seen within 6 months, or if they do need treatment, then they're referred to somewhere where they can actually receive treatment. For the folks, a lot of the people that we see come through African Services Committee aren't insured, as you'll see here soon when I pull up the stats. So a lot of them are actually sent to public hospitals where they can receive receive care through programs where there's a sliding scale fee or free care for those who truly can't afford to pay. The proportion of people from this sample that we have from October 2012 to September 2013 is primarily Senegalese, and the other big countries I've been in, Burkina Faso, Cote d'Ivoire, and Mali. Those are the biggest West African, the West African countries with the highest amount of people that we see. We have a Senegalese patient navigator, and so like a lot of our efforts are kind of steered around the fact that we have a lot of really good connections in the Senegalese community here in New York City. So I'm just going to go with this. I just want to ask you folks if you know what the recommended age for screening is for African-born hepatitis B patients. That means those folks with hepatitis B who were born in Africa. Okay, just give it another couple of seconds. So as you can see, kind of when you're clicking through and you're getting the results come up, about 60% of you are saying 20 years old, which is actually the correct response. So according to the AFLD, folks who have hepatitis B who are from Africa should be screened at 20 years of age for liver cancer. So it's really important that this just kind of underlines the urgency for outreach and screening in these communities that are at high risk for hepatitis B. As you can see here, the median age for the people that were screened in our program, the West Africans, was 47 years of age. And since the guidelines suggest that people are screened for liver cancer at age 20, that's a really huge gap, and the health of these patients where they're not being screened for hepatitis or for liver cancer, even though they have hepatitis B. So such a huge amount of people who are flying under the radar essentially. So that also just underlines the urgency again, the need for culturally competent outreach and screening programs, as well as access to care. So it was primarily male, though, in our sample. Most folks have lived in the United States for a long time, 13 years. That's a long time to go without being screened for hepatitis B. So you can see that we have a population that's pretty vulnerable in the sense that they're not being picked up, even if they are in primary care. I have a story of a gentleman who actually was infected with hepatitis B but had been here for a similar amount of time, around 10 years, with a couple of children and had been to primary care but had never been screened for hepatitis B. So it's something that Chari was talking about earlier, where folks have to ask their primary care providers to screen them for hepatitis B, but because otherwise they're not being asked if they want to be screened for hepatitis B. And we have an extremely low amount of folks who are insured or have a primary care provider. Our staff actually we've updated them. Unfortunately, I wasn't able to put them on slides, but we're still seeing only about a quarter of people who are actually have insurance for a primary care provider. And as you can see here, the core antibody, or the serological marker for current or previous infection, is about 75% for men, 72% overall. But the global rate is actually more about 30%. So it's over twice the amount for West Africans. It's 2 times as much for West Africans as compared to the worldwide average for exposure to the hepatitis B virus, so indicating, again, current or previous infection. In our program, we were able to navigate 92% for medical evaluation. I'm sorry, in this it was 66 folks by the end of September 2013. Our most recent numbers indicate that we've so we've actually screened to date 1,528 West African folks. The rate was 12%, so 183 folks who were positive for hepatitis B, and we've had 137 folks who have attended an appointment, and 35 who are actually in the process of being linked to care. So we have this model where we have a culturally proficient patient navigator. He's from Senegal, who's able to contact, who's able to counsel, and navigate these folks to care, either at Mount Sinai, where they're seen as part of our research program, or at the public hospitals such as Harlem or Bellevue Hospital here in New York City, where they're able to receive low cost or no cost care based on their individual situation. Of those who weren't infected, we were able to vaccinate about 90 people. And this kind of highlights the same kind of sentiment that Chari was sharing about how I feel fine, so there's no real reason for me to see the doctor. It's the same. I think it's the same kind of thing with being vaccinated. I think most people are relieved to find out that they don't have hepatitis B, but not everybody has hepatitis B vaccination as a priority in for those folks who for those folks who aren't infected, it's not a real high priority to be vaccinated. I'm seeing a question here about, for those who don't work in a clinical setting. Oh, Chari might address that for you folks. So 10% of the folks that we screened actually were already vaccinated prior, and then 15% showed evidence of being infected and then actually clearing the infection and not having the surface antibody titers or the serological markers for the protection against hepatitis B, so the marker that confers immunity. 15% of the folks that we screened didn't have that marker, so it indicated that a lot of people in this population actually were previously infected and then unable to, previously infected and then it's been such a long time since they've been infected that they've had these waning hepatitis B serological markers. Moving on, I'm going to have to kind of keep moving forward. So a lot of the research that's been going on actually a lot of the research for hepatitis B has been focused around Asian communities, and there's not been a lot of information about sub-Saharan African or even, or furthermore, West African communities, and trying to understand what kinds of factors affect access to screening and linkage to care, so that we can get these folks not only screened, but actually into care where they can have access to treatment and be followed, because there's beyond just getting people into care. There's another challenge of keeping folks into care and having them check in with the doctor every 6 months once they have access to care. And I'm going to kind of skip over the last couple of slides. I'm sorry, I'm running out of time here. But just to speak a little bit on the major themes that we've had when we've spoken to people about the barriers to care. These are direct quotes from the folks that we've spoken to previously about what kinds of things are keeping them from getting care. And you can see it's direct and indirect disclosure. Hepatitis B knowledge is pretty low, and there's not a whole lot of access right now to begin with, but there's even less access that's culturally sensitive and that avoids scaring people, and the fourth is that we have to continue to engage religious establishments and social networks. So religious establishments, churches, mosques, have really been proven to be like big partners for us in terms of reaching a lot of people. And so it's important to keep it's important to make sure that people know that the screening that you'll be doing is confidential, and trying to maintain people's trust in terms of making sure that they know that you have nothing to do with immigration. That you will be not sharing the information with anybody. It sounds very basic, but it's actually a very important step, I think, in gaining the trust of the folks that we've seen here in New York City. There's an obvious need to increase health literacy surrounding hepatitis B. As you can see, there's a lot of people. This woman suggests that there's a lot of people that have hepatitis B that don't know it. That's something that we all know. She knows that you can feel healthy and feel healthy and still have the virus. And then one day you can develop serious liver disease, or it seems to develop serious liver disease when all along it's been progressing. The final, these are the last couple of slides. I apologize. So there's a lack of access to information and to care, and I think stigma is always going to be something that we're fighting. But until there's actually steady access to care, I mean, that's going to be the biggest barrier that we see. in terms of getting people to care, especially this West African community. And this is just a slide that to support, we just need to continue to engage the community and get the conversation started between families, between friends, and between congregant members, whatever it may be, but to really make sure that we're able to keep the conversation going. And thank you. And these are our acknowledgement. These are our partners, partners at Bellevue Harlem, and our funders, our pharmaceutical funders, and also the Centers for Disease Control and Prevention grant that funded this research. Thanks, guys.
Thank you, Aaron. Our final presenter is Robert Gish. Dr. Gish is the medical director for the Hepatitis B Foundation. Dr. Gish?
Greetings. Can everybody hear me okay?
Yes, we can.
Fantastic. I always like to do that sound check. Hello, everybody. The next 10 minutes or so, I'm going to be moving through some real-life experiences about testing and linkage to treatment and care and some of the barriers in the African immigrant community. And I'll be using some of the lessons that we've learned and research we've done in the Asian immigrant population. I work in California, Nevada, and Arizona. I'm licensed in all 3 states and have a very diverse patient population, depending on where I'm working. And one of my, I'd say, biggest experiences or life-changing experiences was with a Burkina Faso man who was about 30 years of age, who presented to me with co-infection of HIV, hepatitis B, and Delta. He was an engineer who had been working in Moscow and then moved to Reno, Nevada, and then was transferred to our clinic and our inpatient unit in San Francisco, and presented with a CD4 count of about 50, HIV level in the 30,000 range, and full-blown AIDS, and he had no idea of his HIV or hepatitis B diagnosis. This took very aggressive management with multiple antiviral agents, education, treatment of his PCP pneumonia to save his life, and barriers, education. He was a highly educated man who apparently had acquired hepatitis B from a Russian wife who he had married, who'd been a previous sex worker in Moscow. And let's walk through some of the information that we have here. And I'm not going to go into all the numbers, because you've heard a lot of details today, but talk more about direct experience. We've talked about the numbers of African immigrants in the U.S., and as you've heard, there's a huge geographic, I call it diaspora or diffusion across the U.S. Here in San Diego, where I live, and I'm working at a federally qualified health clinic that's almost in the heart of the Somalian, Eritrean, Sudanese community. And these individuals are cared for in this community clinic, and also by 2 doctors who are Ethiopian, who are in that direct neighborhood in El Cajon. And that's some of my local experience and knowledge and awareness of barriers. And of course, when we're dealing with this, we are dealing with language issues. You can move to Nigeria, where the number of dialects far exceeds 40. And the income/poverty level is very diverse. Some of the immigrants are here, as you've heard, illegally and working, entry-level jobs, and others come here, they're highly educated and are working in management positions. One of my patients was from Nigeria. His father ran 3 of the major hospitals in Nigeria and is now managing a major clinic in the peninsula in San Francisco. And each one of these individuals has to be looked at from all these different aspects, and you have to be customizing your communication with them based on what you know about their education, literacy, knowledge, and we'll talk about some of the other barriers and issues that you have to address. Religious and cultural perceptions are very important. as you know, both in Northeast Africa and West Africa, you have either a dominant Christian population or Muslim population, and each of these populations have different perceptions about disease and disease management, as well as methods where we would be communicating with those patients. So this is talking about physician diversity. I'm always looking for partners in my communities where the physicians are from sub-Saharan Africa, specifically what country they're from, what language they speak. On this slide, we're talking about physician diversity and some comments about Asian subgroups, but I think the same thing applies to looking for partners in the African American community that are immigrants that can also help address some of these important issues. Having a doctor, a gastroenterologist from Ethiopia who is embedded in that community from the Horn of Africa region and those immigrants has been very, very helpful. He helps us with lectures in the community, newspapers, radio, and other awareness efforts to bring the hepatitis message, hepatitis B message, and also helps with the HIV message and testing and linkage of care to this community. The nursing diversity is also important. If you can have nurses, NPs, PAs, or medical assistants who are aware, culturally aware, and language aware, it can help with your screening and linkage and educational processes. This limited English proficiency is important because sometimes you're faced with either a language line over a telephone where they may not be speaking the dialect that's most familiar to that patient, or family members. Often it's children who may be very English proficient but not be proficient in medical terminology. I think it's very important to be sensitive to these issues and look for the best form of interpreter that you can have. Many of the clinics and hospitals require a professional interpreter and don't allow for family members to be recorded as the official interpreter for an interaction. Now, these perceptions and misperceptions are important because some of the patients that we deal with are both deterministic and fatalistic, and that this disease may be deemed the unavoidable part of life, and an intervention may not be possible or necessary or specific to their culture. I'm going to jump back to Asia just for a moment with the Hmong, that their belief is that the length of life is predetermined, and there's no reason for some type of intervention that could be deemed life-saving care because it wouldn't necessarily affect outcomes. I've discussed these issues also with a number of my patients from Africa who are African immigrants, and indeed, especially some of my older patients, older meaning older than 40 or 50 years of age, have very, very similar impressions about medical care and medical interventions. And of course, there's always trust and communication that have to be established, and sometimes these can be overcome by finding a specific leader in the community that has a disease state that then can take that message back to their specific community in language and be sensitive to cultural issues that are also age stratified. This distrust of Western medicine is even prevalent somewhat in the United States. The African American community in the U.S. has a certain level of distrust of U.S.-based medicine, and it's important to be cognizant of this and be sensitive to this when you're dealing with patients from the African immigrant community. Relations with the healthcare providers, sufficient time, showing respect for the adults or senior members of the family, very important to not be posing irrelevant recommendations to their disease state. The next slide moves back to what we've learned from our Asian patients and knowing about what the level of poverty level is in those individuals and access to clinics, transportation times. There's a rule that I have deemed very appropriate that most patients don't want to travel more than 20 minutes physically to a clinic, so you really have to take the care to those individuals. That's one of the reasons why in San Diego that I'm working in the eastern part of San Diego in a medically underserved area, and I'll be available not just in person for that clinic, but also by telephone, telemedicine, and emails for their specific patient and patient questions. Employment issues are important. These individuals are often working during the day, and late afternoon, evening, or Saturday clinics, I believe, strongly enhance access to care. They're able to maintain their jobs and yet still access medical care. And again, you need to have the right staff and the right language capabilities for those. You've already heard about the issue about immigration, illegal immigrants, and you have to be very sensitive to this across all of our patient groups and ethnic groups, immigrant groups that are there. The perceptions and misperceptions about hepatitis B being infectious, hugging, kissing, food utensils, and others, of course, do not transmit hepatitis B. But we need to be able to communicate this to our patients in an appropriate fashion and make sure that those individuals are not stigmatized or ostracized from their families, because that further forms a major barrier to clinical care and clinical access. This has been a problem in our Somalian, Eritrean, and Sudanese patients, as well as Ethiopian patients, where there is stigma associated with these infections, especially in the older patient population. We want to, of course, reassure our patients. We want to spend time in language on education about what tests mean, be sensitive to the cultural attitudes, learn about the cultural attitudes of those patients, and I depend very much on family members to teach me during the first contact and interview, and also staff that are in the same culture or in the same language or dialect. It's very important to listen to those individuals and find out what the needs are of the specific patient, how we can customize our knowledge base about hepatitis B to those individuals. Healthcare providers, the good news is that at all the facilities where I work in Northern California through the Stanford Healthcare System, Nevada and Las Vegas, which is a Stanford outreach site, here in San Diego through our federally qualified healthcare clinic, and in Phoenix, there are cultural training events that take place annually. I took one this weekend from my Phoenix program, and they're quite focused on this at each of the institutions today. This is a major change from 5 or 10 years ago, where cultural training, cultural sensitivity training was basically non-existent. You've heard about funding, equal access, lobbying, what's happening with the CDC and HHS, and yes, we're trying to keep hepatitis B at a very, very high level of awareness. So we have to change the perceptions and misperceptions about hepatitis B. Hepatitis B is not curable, but it's treatable and controllable. We need to have callback systems for those individuals to bring them back to clinic. We have to be culturally and language competent to engage those patients, not necessarily using fear or scare tactics, but just solid education about the importance of follow-up care. I think we've highlighted most of the issues on this slide, so I'm not going to repeat this. Last couple of slides have to do with barrier issues that are listed on the specific slide. Again, I think we've covered most of these. And the last 3 slides, which I'm going to move through very quickly, but are specific research results we've had here in San Diego, highlighting lack of insurance, medication that's too expensive, no direct physician or provider access. That includes NPs and PAs. Not familiar with where the clinic locations are, and of course, language issues. And finally, and last but not least, but internet access is markedly limited in the immigrant population. You can't just have internet access, but you have to have language access as well. That's specific to that immigrant group and immigrant population. I want to wrap things up and just talk about Hepatitis B Foundation and linkage to care for hepatitis B that's taken place over the last decade. There are multiple steps that can take place that can operationalize testing, education, and linkage to care. This is a slide that talks about testing. I want to highlight again that hepatitis B core antibody testing should be part of that serologic testing process. Patients who are hepatitis B core antibody positive have been exposed to hepatitis B and don't need vaccination, but what they need is education about the risk, albeit low, of hepatitis B reactivation if they were to become immune suppressed. This can happen in the HIV hepatitis B co-infection community. So all 3 tests are critical for hepatitis B screening, and the providers that are involved with patient education must know how to interpret all 3 tests and link those patients to either care, vaccine, or education. Last 2 slides just have to do with hepatitis B free, and this has been focused heavily on the Asian community on the West Coast and then nationally. But everybody who walks into our hepatitis B free screening programs, no matter what their ethnicity, culture, or language, are able to access hepatitis B testing and linkage to care. Barriers we've talked about extensively, and this is just highlighting that last barrier message. And we need to make sure healthcare providers are also not a problem in terms of the barrier aspect that takes place with our patients. And last 3 slides, I'm just going to just hit just for a moment, having to do with education levels. And I've finished right on the 15-minute mark. So thanks very much. These slides are available for other people for discussion or education at another time point. Thanks again for having me.
Thank you, Dr. Gish, for that excellent presentation. In closing, we would like to inform you about the National African Immigrant and Refugee HIV/AIDS and Hepatitis Awareness Day, also known as NIRA. As noted by the information shared by the presenters, African immigrants constitute a highly diverse and rapidly growing group in the United States that is disproportionately impact the HIV and hepatitis B. Hence, a group of individuals and community-based organizations convened to establish September 9th as National African Immigrant and Refugee HIV/AIDS and Hepatitis Awareness Day, NIRA Day. Similar to other HIV/AIDS awareness days, the purpose of NIRA Day is to bring national and local attention to the HIV and viral hepatitis needs of the African immigrants living in the U.S. in a culturally and linguistically appropriate manner. The creation of a National Awareness Day will also support the eradication of other epidemics fueling or related to HIV disparities among African Americans, including tuberculosis, substance use, and mental health. There's just 2 things that I wanted to note in terms of establishing a national Awareness Day for African immigrants and refugees, and that is that recently APHA released an article sort of questioning the relevance or need for national awareness days. And I think one of the things, and I was proud to see that HHS stepped up to the plate and gave a strong reaction in support of national awareness days. And for those of you that are on the phone and are familiar with AIDS.gov, it's an excellent sort of clearhouse, warehouse for information related to national awareness days. But I think one of the things that I wanted to call to everyone's attention is that in terms of eradicating health disparities, I think we all are clear that it's going to take a comprehensive approach to do so. And a lot of times as providers, because we are oftentimes overeducated or have sort of a baseline education around issues, we tend to make assumptions about what the community's level of knowledge might be. And as we learned from some of the presentations today, where there are the target population has limited access to internet and really have a need for education, I think it's important as providers that we use National Awareness Days, in particular NIRA, to create that advocacy and awareness that's needed in communities and use these days as opportunities to educate folks in our community. And I think that as we think about sort of the utilization of National Awareness Days, that again for providers they may not feel like they serve a purpose, but definitely for the communities that we're serving, they definitely serve a purpose for undereducated communities that are experiencing health disparities. For more information about NIRA, please go to www.macboston.org. And that's www.mac/boston.org, or hyphen rather. Also, each organization or individual can join the initiative and can host an event on September 9th.
Thank you to all the presenters. Now we will answer the questions that were posed during the webinar through the chat feature. So our first question is to Chari, the presenter. Chari, the presenter made mention about non-contact via breast milk, but HIV can be transmitted via this node. I think they are of the same family. Please explain further.
Yes, so even though HIV can be transmitted through breast milk, hepatitis B is not. Breastfeeding is not a transmission route for hepatitis B virus. So they are two completely separate viruses. And so it is safe to breastfeed while a woman is infected with hepatitis B. And the other thing to remember is that babies who are born to infected mothers, they start the vaccines and they're given an extra dose of antibody at birth. So they start their protection right away, and they complete their vaccination by 6 months of age. So between the fact that hepatitis B is not transmitted through breast milk and the fact that babies are getting getting the vaccines, it's not considered to be a transmission route. So it is safe to breastfeed.
Okay, and then Chari, the next question is, what are the HPV screening options for those who do not work in a clinical setting?
Sure, I can talk first, and then I know Aaron and Dr. Gish can definitely jump in. So there are, I know Dr. Gish mentioned Hepi Free, and we also have Hepi United. There are sites around the country, local community coalitions that work to provide free community-based hepatitis B screening to all communities, particularly high-risk communities. So thinking about Hep B United, if you go to hepunited.org, you can find a map of a Hep B United site around the country. And if you find a site near you, and hopefully you will, we have 24 different sites. If you find a site near you, you can contact them and find out when and where they do their screenings. Typically, we travel throughout cities. We go into different communities. We go into churches and restaurants and community settings and centers. And that is a great way. So working with the Hep B United site or a Hep B Free site is a great way to bring free hepatitis B screening into your community. And if you have any more questions, feel free to email me or call me, and I can try and link you up with a site.
Okay, and we actually have a couple more questions. So the next question is there a rapid test for HPV?
Do you want me to take that one?
Sure.
Gish. And unfortunately, the answer is no, but that may change in the next 12 months. There is a company who is working on a phase 3 study for rapid tests for hepatitis B. And in fact, the rapid test will include B, C, and HIV all in one package. So I'm optimistic, but until it's FDA approved, we'll have to say that's on hold.
Okay, and then the final question is, in Muslim communities, what is the best way to reach women in a mosque setting?
I can take that one. So the strategies that we've actually used in the past are reaching out actually to whoever's in charge at the mosque. In general, we tend to speak to an imam or a social coordinator who's associated with a particular mosque. And sometimes, but not always, there's a women's group as part of the Islamic Association. So many of the mosques that we tend to visit to do screening, there's a particular women's group who meets, for example, at a separate time for other activities, and they generally have somebody who coordinates it, and we tend to reach out to that person and try to set things up. That's the strategy that we've taken in order to screen women in the mosque setting. We've also done screening after prayer on Fridays, where we do screening for both men and women at the same time. In which case we have our female staff members who are screening the women and the men screening the men.
Thank you, Erin. Thank you, presenters and participants. If you have additional questions or your question didn't get answered due to time, please let us know via email. Thank you for participating in this webinar on improving hepatitis B prevention, screening, and clinical care for African immigrants. This is the last webinar of our series titled The Hidden Epidemic, HIV and Hepatitis B Prevention, Screening, and Care Among African Immigrants. If you have any questions, please contact Chioma Naji. Contact information is provided. Immediately after we close the webinar, you will receive the evaluation. Please keep your web browser open and the evaluation will appear immediately. Please complete. The evaluation will provide vital information to help improve the webinar and also document who participated. Attendees who are requesting nursing and social worker continuing education units are required to complete an evaluation form. A certificate will be emailed and/or mailed to participants within 4 weeks. Thank you again.